This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the journal Brain and Behavior, published in 2026. It's titled Early versus Delayed Cranioplasty After Decompressive Craniectomy, a Systematic Review and Meta-Analysis by Taha and colleagues.
This is a topic that hits home for anyone taking call in a trauma center. We perform a decompressive craniectomy, or DC, to save a life by quickly reducing intracranial pressure and restoring cerebral perfusion in cases of malignant intracranial hypertension, whether that's from a TBI, a massive ischemic stroke, or an ICH. But then we're left with the second act, the cranioplasty.
Exactly. And while we know cranioplasty is essential to protect the brain and restore the cranial contour, there's always been this lingering debate about when to go back in. We know that cranioplasty might actually promote neurological recovery by improving cerebral spinal fluid dynamics and cerebral blood flow, but the timing is the sticking point.
Right. In this meta-analysis, how did the authors define the timing? Because early and late can be subjective.
The authors standardized the definitions based on the current literature. Early cranioplasty was generally defined as occurring within 2 to 3 months after the initial decompressive craniectomy. Delayed cranioplasty, on the other hand, was performed after 3 to 6 months.
It's a classic neurosurgical trade-off. Proponents of early CP argue it reduces rehabilitation time and enhances motor function, the whole syndrome of the trephaned argument. Plus, from a purely technical standpoint, we often say it's easier because there's less scar tissue. But the delayed camp worries about infection and wound healing. What did Taha's team find when they crunched the numbers?
They conducted an electronic search across PubMed, Embase, and Cochrane, and used the Newcastle Ottawa scale to ensure the quality of the studies included. Let's start with the surgical efficiency metrics, because the results there were quite striking.
I'm guessing the operative time favored the early group.
Significant so. Early cranioplasty resulted in a significantly shorter operative duration, with a mean difference of negative 26.76 minutes. The p-value was 0.0003.
That's nearly half an hour saved in the OR. For a resident or an attending, that's the difference between a smooth dissection and a tedious battle with dense adhesions between the dura and the scalp flap.
Exactly. And it wasn't just time. They also found a significant reduction in intraoperative blood loss in the early group, a mean difference of negative 21.53 milliliters, with a p-value of 0.01. So the technical advantage of early surgery that surgeons often talk about seems to be backed up by this data.
That makes sense. The planes are often much more forgiving at the 8-week mark compared to 6 months out. But we can't just look at how fast the surgery is. We have to look at the complications. Cranioplasty is notoriously high risk for such a simple reconstructive procedure. What did the meta-analysis show regarding safety?
This is where it gets interesting, and perhaps a bit cautionary. When looking at overall complications, early cranioplasty actually showed a higher risk. The risk ratio was 1.43. However, it's important to note that this was non-significant, with a p-value of 0.22 and a 95% confidence interval ranging from 0.81 to 2.53.
So, a trend toward more complications in the early group, but it didn't reach statistical significance. What about the one we all fear, postoperative infection?
Similar story there. Early cranioplasty was associated with a non-significant increase in postoperative infections, with a risk ratio of 1.36. Again, the p-value was 0.65, so it wasn't statistically significant. The authors noted a moderate amount of heterogeneity in these results, with an I-squared of 57% for overall complications and 38% for infections.
That's a crucial point for our listeners. While the early group is faster and cleaner in the OR, there might be a biological price to pay if the scalp hasn't fully recovered or if the inflammatory milieu hasn't settled. If you're at 1.43 times the risk for complications, even if it's not statistically p less than 0.05, it makes you pause.
Definitely. And when we look at functional recovery, the study looked at Mini Mental State Examination, MMSE, and Glasgow Outcome Scale, GOS scores. Surprisingly, the neurological outcomes actually favored the delayed cranioplasty group or showed no significant difference.
Wait, that's slightly counterintuitive. We often tell the families that putting the bone back early will jumpstart the patient's recovery.
Right, that's the common narrative. But based on the data synthesized here, that early boost didn't translate into superior MMSE or GOS scores compared to the delayed group. In fact, for some measures, the delayed group had the edge.
This highlights why we need these meta-analyses. Our clinical anecdotes about the patient who woke up right after the bone flap went in might be suffering from selection bias.
Exactly. The paper concludes that we are looking at mixed results. On one hand, you have shorter operative time and less blood loss with early cranioplasty. On the other hand, you have a trend toward more complications and potentially better, or at least equal, long-term neurological outcomes if you wait.
So, for the residents listening, what's the takeaway when they're sitting in the clinic with a patient who had a DC 2 months ago?
The authors are very clear that we need a prospective, multi-center, randomized controlled trial with specified outcome measures to really establish the balance between surgical safety and functional recovery. Until then, the timing should probably be individualized.
It really comes down to the patient's specific physiology. If they have significant syndrome of the trephined, where they're neurologically declining because of atmospheric pressure on the brain, you might accept that 1.43 risk ratio for complications to get that bone back in. But if they are stable and still recovering from a systemic standpoint, waiting until that 3 to 6 month window might be safer.
And we shouldn't forget that the study noted that early was 2 to 3 months. Sometimes we see people pushing for cranioplasty even earlier, like 4 to 6 weeks. This study suggests that even at 8 to 12 weeks, we're already seeing that trend toward increased complications.
It's a great reminder that faster in the OR doesn't always mean better for the patient's overall course. That 26-minute time saving is great for the surgeon's schedule, but not if it leads to a return to the OR for an infected bone flap.
Precisely. The study really emphasizes that the optimal timing of cranioplasty remains a subject of ongoing debate because of these conflicting priorities, surgical ease versus biological stability.
Well, this has been a great deep dive into a very practical problem. To recap, early cranioplasty within 2 to 3 months gives you a shorter operative time and less blood loss. However, it carries a non-significant but higher trend for complications and infections, and doesn't necessarily improve functional scores like the MMSE or GOS compared to waiting 3 to 6 months.
That's a perfect summary. It really shows that in neurosurgery, sometimes patience is a virtue, but the technical benefits of early intervention are hard to ignore.
Thank you, Dr. Alara, and thank you to our listeners. We hope this helps you the next time you're planning a reconstruction. This was the Neurosurgery Hub podcast. I'm Dr. Aris.
And I'm Dr. Alara. See you in the next episode.